Welcome back to Med School Mind Maps, everybody. Today I'd like to talk about cirrhosis of the liver. Now, cirrhosis of the liver can be split up by quite a few different etiologies, and I'm going to break it all down for you. So we're going to talk about things that feed into cirrhosis, things that cirrhosis leads to, and then we're going to dive deeper into actually what causes cirrhosis, and then the facts and things y'all need to know about those specific things. So let's start off by talking about what cirrhosis actually is. So you can see here in blue that cirrhosis is basically just the formation of regenerative nodules around fibrosis. So you have a lot of fibrotic tissue that compress the hepatocytes and liver functional tissue, and that's what forms so-called regenerative nodules. But how is that caused? So we can see that whenever you have severe hepatocyte injury, a cytokine is released, and that cytokine is TGF-beta. And what happens is that TGF-beta is actually going to activate stellate cells, which are cells that are right next to the sinusoids of the hepatocytes. You can actually see that in an illustration here. So you have sinusoids here, and then this is where the stellate cell would be. This is more just an illustration of fibrosis of the stellate cell. All right. So what happens is the stellate cell will form a myofibroblast, which is just a cell that can produce collagen, and that collagen will be type 1 and 3, which then forms regenerative nodules. And again, those regenerative nodules can compress the hepatic sinusoids. And this is important because it impairs the blood flow through the liver. All right. So we'll go ahead and talk about the different signs and symptoms you'll see from cirrhosis. So you can imagine if you have these regenerative nodules that are compressing on the liver, impairing blood supply into the sinusoids, which are right next to the basal end of the hepatocyte, you're going to have a lot of blood that's backed up, all right? And that blood then starts to, it's backed up, so the pressure starts to increase, and you get something called portal hypertension. And this is just blood that's been backed up. You can't go through the liver. It's having a hard time doing that, so it backs up into the portal system, backs up into the gastric blood supply, the spleen, the lower intestines, and so on. And you get these following symptoms from portal hypertension. We're going to start out with what happens when venous drainage is impaired from the spleen. So the spleen vein, obviously you'll get splenomegaly, that blood will back up into the spleen, and the symptoms you can have with splenomegaly, obviously, it's on the left side, so left upper quadrant discomfort, early satiety, so it kind of compresses the stomach, causing you to feel full earlier. And then, of course, if you've got a splenomegaly, you're going to have hypersplenism, and that's going to lead to cytopenias. You can imagine if a lot of blood is in the spleen, you're going to have splenic sequestration of platelets and white blood cells. So if you went and took a CBC, it wouldn't show as many platelets and white blood cells from that because they're all hanging out in the spleen. So next we'll talk about the left gastric vein. So if blood backs up there, you're going to have esophageal varices, which are basically just veins in the esophagus that are potentially or are typically closed off, or very little blood goes through them. They're very much just communicating veins. But when blood gets backed up into the esophagus, they kind of open up, blood rushes in, and they get big, and they can sometimes burst, and that leads to bleeding. Very, very dangerous thing when that happens. You'll throw up blood, and also have melon in the stool. And then we talk about the inferior mesenteric vein. You got things that can happen are caput medusa, which are just dilated superficial abdominal veins you can see there. So if your inferior mesenteric vein's backed up, that's where the blood ends up, in those superficial abdominal veins. And then, of course, hemorrhoids. So again, the inferior mesenteric vein drains blood from the rectum area, and you can end up getting hemorrhoids. All right, so another thing that you can have besides blood backing up with portal hypertension is obviously more blood, more hydrostatic pressure. And again, that hydrostatic pressure causes blood to get pushed outside the vessels, and that will cause ascites, which is just fluid outside of where it should be in the peritoneum, and that leads to bloating, and to treat that, it's paracentesis. We'll talk another bit about how ascites is caused through cirrhosis here in a minute. All right, so that's portal hypertension. So we're going to move on to other causes. One last thing is portal hypertension can cause hepatorenal syndrome. And what hepatorenal syndrome is because you have all this blood that's backed up, and you have very constricted just sinusoids, and the blood's not really getting where it needs to go. The body's going to compensate for that by releasing nitric oxide. Again, nitric oxide is a very strong vasodilator, and that can affect the kidneys by increasing the, I guess it would be vasodilating the afferent efferent tubules of the kidney, which obviously that would lead to a decrease in GFR if the efferent is dilated, and that's going to cause an azotemia, and this would be a pre-renal azotemia, remember. So it's not happening at the kidney itself. And remember, if you have a pre-renal azotemia, you're going to have a BUN creatinine ratio of 15 to 1, okay? It's 15 to 1, again, because you're absorbing more nitrogen to increase the blood osmolality, or increasing more urea nitrogen to increase the blood osmolality, because the body thinks that you need to do that, right? So you need to increase blood osmolality to decrease the edema, hence the pre-renal azotemia. All right, so that's hepatorenal syndrome. We're going to move on to some more signs and symptoms of cirrhosis. One is decreased protein synthesis. So what happens with cirrhosis is, again, the liver is one of the liver's main jobs is to synthesize proteins such as albumin and clotting factors. So you got factor 7, vitamin K, etc. So if you can't synthesize the clotting factors, you're going to have increased bleeding. And then if you can't make albumin, then you're going to have lower oncotic pressure, which then can cause ascites. So blood escapes the blood vessels. And again, two different mechanisms for how ascites is caused through cirrhosis, but both on physical exam present with abdominal distension and a fluid wave shifting dullness. On lab, if that progresses to bacterial peritonitis, which is just the bacterial infection that goes along with ascites, it's very common. If a patient has ascites, it kind of creates an environment very habitual to bacteria. So that can unfortunately happen, but on lab, you will see increased white blood cells and the acidic fluid, and that suggests that it's going to be bacterial peritonitis. And remember, neutrophils more common with bacteria. I'm going to go ahead and talk about that real fast. So the two bacteria that you should be familiar with for bacterial peritonitis is gram-negative Klebsiella pneumonia and Escherichia coli, right? So both two bacteria there that can cause that. All right, so this presents kind of how you would suspect is, well, first of all, it can be asymptomatic, but if it's not, you're going to have fever, chills, abdominal pain, and an ileus, or worsening encephalopathy. And again, to work this up, you're going to want to do a culture of the peritoneal fluid, and then you're going to have an elevated white blood cell count, mostly neutrophils or polymorphic neutrophils. All right, so we're going to move on and talk about another issue that can be caused with cirrhosis, and that would be you have altered sex hormone levels. Now, there's two ways, or there's really mainly just one way that this occurs, but kind of two mechanisms. First of all, the liver's job is to metabolize estrogen. And if you can imagine, if the liver's getting all fibrotic and scarred, then can't metabolize estrogen, so you're going to have more estrogen in circulation. As well, another way is estrogen also stimulates the synthesis of sex hormone binding globulin, so it's kind of a double whammy. Sex hormone binding globulin is a molecule that binds up free testosterone and lowers active testosterone in the body. So by increasing estrogen and decreasing testosterone, you have more free estrogen in the blood, and mainly you get three side effects or symptoms from this free estrogen. You get palmar erythema, which you can see right here, spider angiomas, you can see here, and gynecomastia, or men growing breasts. All right, so those are mainly, okay, so we're going to talk about one more here. So you have hepatic encephalopathy. And what hepatic encephalopathy is the liver can't really get rid of that ammonia in the blood. Because one of the liver's job is the urea cycle. So you have free ammonia in the blood. Liver can't get rid of it, so you're gonna have increased ammonia, as well as GABA and glutamate. It's gonna lead to cell swelling, and what happens is you have all these symptoms here. So again, ammonia can be very toxic to the body, especially the neurosystem. So you're gonna have neuromuscular abnormalities, primarily asterixis, and asterixis is just the flapping of the fingers right here, and ataxia, which is just trouble with balance and then slurred speech, as well as coma. Sleep cycle is going to be a little off. Your speech can be a little slurred, confusion, changes in behavior as well, such as bizarre behavior, you have lower inhibitions, and you can experience some euphoria. Looking at the histo of this, you can see some astrocytes, which have enlarged watering nuclei with no visible cytoplasm and prominent nucleoli. All right, so some astrocytes here, some here, just affected by the ammonia. All right, so to treat hepatic encephalopathy, what you want to do is you're going to want to correct the precipitating event. Once you do that, you want to lower blood ammonia. You do that by increasing lactulose, which is going to act to lower pH, which makes ammonia into ammonium, which then traps that in the colon, lowering it. All right, so moving on, we're going to talk about some of the gross things you can see with cirrhosis. And this is mainly going to lead us into the etiologies of cirrhosis. But first, we're going to talk about macronodular cirrhosis. And this is just mainly just saying that the nodules, remember you have regenerative nodules here with fibrosis around it from, remember, those stellate cells. And what happens is in viral, you tend to have a more macronodular pattern, which is where the nodules are greater than 3 millimeters. Mainly all you need to know. And then for alcohol, just know that it's a micronodular cirrhosis, and those nodules are going to be less than 3 millimeters. All right. So now we're going to get into more of the clinical causes of cirrhosis. There's a bunch, so we're going to go through them one by one. How we're going to do this first is we're going to start by talking about viral causes of cirrhosis, and then we're going to move on to alcohol causes of cirrhosis, and we're going to touch on some less common causes, such as primary sclerosing cholangitis, hemochromatosis, Wilson's disease, alpha-1 antitrypsin disease, or cystic fibrosis. So we'll move on to that in a little bit. But first, what I want to talk about is viral causes of cirrhosis. And there's 5 that we're going to touch on today, and they're all similar names: hepatitis A, B, C, D, and E. Start with hepatitis A, and then we'll move on to the rest. Before we do that, though, I kind of want to touch on the general stuff that these all can cause. The main method of injury for acute viral hepatitis is whenever that virus gets into the hepatocytes, you're going to have an immune response, and that's mainly going to be a CD8 T cell, so T cell lymphocyte, that's going to cause the hepatocyte to undergo apoptosis, which mainly is just a ballooning degeneration of the hepatocytes, like cell suicide. And you can see that right here. You have this ballooning. And this is actually called acute fulminant hepatitis whenever this occurs. So just remember, acute fulminant hepatitis, CD8 T cell mediated response to the virus. And this occurs in a sequence. So the symptoms occurs in a sequence. You're going to first present with prodromal symptoms, so malaise, anorexia, fibromyalgia, and fatigue. And then that's going to lead on to bilirubin elevations, which can present with jaundice, dark urine, pale stools. And then that's going to lead on to hepatomegaly, right upper quadrant tenderness, which can also present with hepatic encephalopathy. Remember that ammonia is increasing the blood. And then if that persists, it can lead to chronic viral hepatitis, which is where just the liver inflammation lasts longer than 6 months. And what the symptoms you're going to see for the chronic viral hepatitis is just going to be either symptomatic or asymptomatic. If it's asymptomatic, you're going to have persistent increases in the AST, ALT, or ALT, AST. But if it's symptomatic, you're going to have fatigue, anorexia, mild jaundice. Fatigue is most common for that. For physical exam, you're going to notice mild hepatomegaly and then hepatic tenderness. And then, of course, if it gets to the chronic phase, it can then progress to the cirrhosis phase, which is more serious. All right, so we're going to talk about some of the more common causes of the chronic phase. It's going to be hepatitis C is what you're going to mainly focus on for the chronic, and then hepatitis B is going to be also common, but mainly focused on C there. Now, B can only really cause it if it's infected with D as well. And that's called a superinfection. See, D needs B to infect the body. And then HDE, hepatitis D, that's mainly more common with pregnant females or immunosuppressed patients. All right, so now we're going to move on to the more let's move down here and let's talk about some lab findings, some general lab findings we'll see with viral hepatitis. First thing you want to be aware of is the aminotransferases. So these are just markers of liver hepatocyte injury. And the AST is mainly going to be more specific for mitochondrial damage, while ALT is going to be more specific for cytoplasm damage or just in general outside of the mitochondria for the liver. So with viral, you're going to see more increases with ALT than AST, so the ratio is going to be presented like that. And then you're also going to have hyperbilirubinemia, conjugated and unconjugated. So how that makes sense is, remember, you have bilirubin that's unconjugated from the spleen. It gets taken up into the liver and then conjugated by hepatocytes and then released into the biliary system. So why you have increase in unconjugated bilirubin is because the hepatocytes have a hard time taking up that unconjugated bilirubin from circulation because they're hurt, and it's also a little difficult to do that. So you have an increase in unconjugated bilirubin in circulation. Why you have an increase in conjugated bilirubin in circulation is because those hepatocytes also leak the bilirubin into the sinusoids, right? So they're not functioning correctly. So the bilirubin that they can get conjugated, they tend to leak that. So that's why you have an increase in both. Another thing that you'll see is you have an increase in urine bilirubin. So urine bilirubin is going to be increased because, just remember, the hepatocytes are leaking into circulation and you're leaking and they can't uptake the unconjugated, so that's going to be also leaked into the blood supply. And again, if it's in the blood supply, it's going to go through the kidneys, and it's excreted into the urine. So that's why that's the way it is. And then you're going to have an increase in urine urobilinogen. And this is the cause because the damaged hepatocytes are less able to take up the reabsorbed urobilinogen. So remember, urobilinogen is reabsorbed, be reused by the biliary system. But remember, damaged hepatocytes, can't take it up, just like they couldn't take up the unconjugated bilirubin. So more is taken up into the liver, or less, so more is to be excreted by the urine, and that's why that is. This is just a quick thing to notice what you order whenever you actually order a virus panel for hepatitis. And you can see you got some HB and some Hep A, some Hep C. We're going to go into more of that when we go into the specific viruses. So looking at what happens grossly in viral hepatitis is you have areas of lobule necrosis and collapse. So you can take a deeper look there. So you're going to have basically necrosis and little ulcers collapsing. This is called diffuse massive necrosis. What happens is the liver becomes pale and shrunken if a significant portion of parenchyma becomes necrotic. So that's basically all you need to know. Hep A, Hep B with Hep D, and then HEV usually are more prone to cause diffuse massive necrosis. So now we've gotten there, let's start talking about more of the individual causes of acute viral hepatitis. We'll go into the individual drugs, or the individual viruses. So we'll start with Hep A, then we'll move right along to Hep D and Hep E. So Hep A is a picornavirus, so same family as like polio or echoviruses or Coxsackie viruses, but it's also an RNA virus. It's actually a positive sense RNA virus. Remember, you can have negative sense, but this one's positive sense, and it's transferred fecal orally. So you can think of people tend to get that are people living in third world countries that don't really have access to clean water, or in America, the most common cause is through shellfish. So shellfish that hasn't been cooked all the way, you can get hepatitis A from this. And what happens is, again, it replicates in the cytoplasm of the hepatocyte, and you're going to have cytotoxic cells as well as natural killer cells that come in and damage the hepatocyte. It can lead to jaundice, dark urine, or colored stools, and mainly this is intuitive to think about. So if you have jaundice, remember the bile is in circulation. You have a lot of bile a lot of bilirubin in circulation. You're going to have less bilirubin in the colon because more of it's in circulation. So that, remember, bilirubin is the main reason why our stools are the color they are. So if you have less, you're going to have pale stools. And then again, dark urine because you're excreting a lot of that bilirubin through the kidney. You're also going to present with nausea, fatigue, low appetite, and stomach pain. It's kind of just symptoms to kind of put in the back burner. This virus has a small risk to turn into acute liver failure, right? So the liver failure, that is the hepatic necrosis. And also, you really don't see a chronic hepatitis, so this is very rare to turn into cirrhosis. And they don't have really big carrier states, so it's going to be gone in about 2 months. This is one of the lesser ones to worry about. Still be on the watch out for because it can progress acute liver failure very rarely. To work this one up, we're going to want to get some hepatitis A antibodies studies. So if they present with IgM, that means the infection is acute. And if they present with IgG, it indicates that they are immune to it, either following the infection or vaccination. To diagnose this, you're going to want to have an increase in ALT over AST, and then positive serology showing that they have acute antibodies or IgM antibodies. The prophylaxis, or the treatment for hepatitis A, is obviously a vaccine. So you can do a vaccine for this one. But if they end up getting it, just treat them supportively. Most patients recover completely fine from this. And if very rarely they progress to fulminar or fulminant hepatic failure, you're going to have to do a liver transplant. However, that's very rare. So hepatitis A, that's it. Move on to hepatitis B. And hepatitis B is a lot more to think about. It's also more dangerous, but it's one of the ones that's caused not by fecal-oral transmission, but it's really caused by IVs or sexual transmission. It can also be passed on from mother to birth, child through birth, and then again, if it can be caused by IV drug use, it can be caused by needle stick injuries. So it's mainly just body fluid to body fluid. Going back into the little background, it's a adenovirus virus that's partially double-stranded DNA virus. So hepatitis A was positive since RNA. This is partially double-stranded DNA. And there's really no pathophysiology that we're going to discuss. Just know that it, again, is taken up by the liver hepatocytes, and this body mounts an immune response that damages the hepatocytes. The manifestations kind of vary mildly. You can either go into an asymptomatic carrier state, or you can present with acute hepatitis, which again is more malaise, nausea, vomiting, anorexia, and jaundice. That can progress to chronic hepatitis with and without progression to cirrhosis. And then if it goes to cirrhosis, it can also, we haven't talked about this, but it can also progress to hepatocellular carcinoma. But what I want you to associate is that acute hepatitis is kind of associated with acute fulminant liver failure. So that necrosis and ulceration of the liver. Okay, some extrahepatic complications are polyarteritis nodosa and membranous nephropathy. And these are both type 3 hypersensitivity reactions. So polyarteritis nodosa is a type of vasculitis involving the renal, coronary, and mesenteric vessels. So it's kind of like affects the heart. Most commonly is idiopathic, but Hep B again can cause it. And what happens is you have transmural inflammation of arterial wall, which causes multiple microaneurysms and spasms on the arteriogram, and this is shown as a string of pearls on imaging. Really significant for acute MIs. Let's move on to membranous nephropathy, also caused by Hep B. Most commonly is unknown, but what happens is the type 3 hypersensitivity reaction goes and lodges on the subepithelial side of the basement membrane. So you remember you have the subendothelial basement membrane epithelial side, so it goes through the endothelial layer and lodges on the epithelial side. So obviously it's very small complexes. This can cause thickening of the basement membrane, kind of said as a spike and dome pattern, so you can see that there. So it causes thickening, and it's on the subepithelial side, and this can present with non-selective proteinuria. So this is a nephrotic syndrome, so loss of protein in the urine. Progresses really slowly, and can also progress to end-stage kidney disease, and or continue prone in the urine, and then a third of them can go into remission. So a very dangerous thing to be thinking about with Hep B. Let's move on to the histo, then we'll go on how to work it up and then treat. So the histo for this is you're going to have portal triads that mainly are affected. So remember, if you have the hepatocytes are kind of split up into portal triads, and you have zone 3 or zone 1, then 2, then 3 that go into the central portal vein. So again, if you have, so it says the portal triads are affected, and then the lymphocytes come in, and then there's a limiting plate of hepatocytes around the triad, and that's breached. And then you have an extension of inflammation into adjacent hepatic parenchyma. So that plate of hepatocytes around the portal triad is breached by the virus, and that inflammation extends into the rest of the hepatocytes, and this can cause focal interface necrosis of hepatocytes, which you can see right here. All right. So now moving on, we're going to talk about some of the ways to treat or work up hepatitis B. First thing I want to discuss is the liver enzymes. So ALT again is going to be AST. AST is usually only higher with alcohol. And then we're going to move on to the antigens that you'll see. So this is a very high yield topic. So the antigens for Hep B, you're going to want to know what each of them does and then what each of them means. So the first one I talked about is the HBsAg, so the Hep SAG antigen. And this is just going to be the surface antigen. This is the first one you'll see for a Hep B infection. And that just signals current infection, right? So if you don't have infection anymore, that one's going to go away. And we're talking about the surface antibody. So the surface antibody is going to be there post-infection or if you're vaccinated. So the vaccine actually is what the vaccine targets, is the surface antigen. So if you have a surface antibody, you're going to have either that's because you had the virus and now you built up immunity to it, or because you got the vaccine. Next one we'll talk about is the core antigen. So the core antigen is shown here, and this is this just kind of shows you a window period. So there's a time between the Hep SAG and the SAG, or the S antigen antibody, that you're going to have this window period where nothing shows up except for the capsule antigen. Okay? So the capsule antigen is going to be present post or current infection, and it's also not in the vaccine. So if the patient has Hep B surface antibody only and no core antigen, then they, or no core antibody, they that signals that, I'm sorry, I forgot what I said. So if the patient has a anti-HBs and an anti-HBc, that means that they did not get the vaccine and they're infected, because the vaccine doesn't provide the HBc, only the infection does, and vice versa. So you can see that there. So you can see anti-HBc can also show you whether you have an acute infection or a chronic infection. So if it's the IgM, it's acute. IgG, remember that B cell is going to transfer to IgG. It's more specific antibody. That's for more chronic infections. All right, so we're moving on. So you can kind of see the algorithm here, and here's the HBe antigen. So the E one is more for a marker of infectivity and transmissibility. It appears shortly after HB-Sag, and it represents circulating intact virions and detectable HBV DNA. So if you have the antigen for HBe, that means you're very infectable, but if you have antibodies, that means lower transmissibility. All right. So let's stop here. We'll move on to Hep C next time. But I feel like this is a good place to stop. So we went over cirrhosis, all the causes of that, or all of the side effects and symptoms for that. We looked at hepatitis A and hepatitis B, and then viral hepatitis and how that can progress to chronic hepatitis. In the next video, we'll talk about hepatitis C, and then D, and then E, and then we'll move on to alcoholic causes of cirrhosis, and then we'll move on